Dr. Hannah Schara. She's the first of the fellows to give their presentations this year, and I commend her for going first. Her topic will be Reminiscence in Narrative Medicine and Geriatrics. Our next grand rounds will be on February 2nd. Over Zoom, we will confirm if there will be a hybrid or not, because that will be our faculty meeting, and so the first of the month should be a hybrid session, but we will confirm later. But as always, there's the Zoom option. That presenter will be Dr. Elizabeth Blumen. Our next journal club is February 9th. That will be over Zoom. That will be Dr. Gilhooly and Dr. Sarah Beck. Following today's grand round, you'll receive an email with a link to the recording of today's presentation and a copy of the PowerPoint slides. Also included in the email will be a link to an online evaluation. Please make the time to complete this link. It's very important. Our presenters value your feedback. This is also a VA activity, and we need that feedback to continue these. Please submit your questions via either the chat or the Q&A. I'll be moderating those during this session. Our speaker today, Dr. Hannah Schara, is a graduate of the University of Colorado School of Medicine and our internal medicine residency program. Her prior research interests include the co-creation of the Medical Student Narrative Book Project and working with the Living Well with Dementia Caregiver Support Program. Future career goals include veteran geriatric primary care and incorporation of narrative medicine and reminiscence into geriatric medicine. I will turn it over to Dr. Schara.
Awesome. Thank you so much. All right, let me start by sharing my slides. Okay. All right. Well, thank you guys for joining me today. As Dr. Orr said, I will be talking about reminiscence and narrative medicine. Really, the only disclosures I have for this talk is that I am in no way a reminiscence or narrative medicine expert. This is just kind of an overview of the research that I have found and some projects that I have found interesting. There's likely many nuances or things that I'm not aware of, but hopefully this will be enjoyable and kind of a learning experience for us all. The overview for today's talk, to start with, I'll define reminiscence. The types of reminiscence and functions is related to kind of how it's looked at in a clinical setting and in research studies. The outcomes of reminiscence therapy, we'll look at some meta-analysis, some specifically with patients with cognitive impairment and some that excluded those individuals. We'll look at the application of reminiscence in different care settings. So we'll look at kind of observational studies in long-term care, and then an implementation study in an acute hospital setting, and also some veterans group studies in home-based primary care and a mental health center. And then briefly, we'll just look at some current narrative medicine projects that are going on nationwide and then here in our institution as well. So what is reminiscence? One of the definitions, one of the most common ones I found is reminiscing is the process of willful or involuntary recall of past events and experiences in one's life. Another definition stated it is thinking or talking about something that is personally significant to someone. And so it's not necessarily just kind of talking about, things that you did last week or kind of, simple things, but really things that are personally significant is kind of what we're thinking of with reminiscence. And with that in mind, I will do a little bit of reminiscing with you all. So these are just some things I have stored away for memories of my granny. I have a letter that she wrote me here. She was an avid letter writer, and I've kept all of her letters, but this is one of the last ones she wrote. And it's probably hard to read her writing, but for the specific letter, we had just talked on the phone, and then immediately she sat down and wrote me a letter of how much she enjoyed our conversation. And that really kind of embodies who my granny was. The pictures, I'll kind of go through. The top one is her and my granddad at his retirement celebration in the 1960s. The picture below that is when my granddad returned from World War II, and the two of them together. And then the one in the bottom is my granny holding me when I was a baby. And then the last one just to the left of that was the last visit I had with her. And she was living in Montana in a nursing facility. I was here in Colorado, but my daughter had recently been born, and she was just over a year at that point when I was able to make the trip to see her. And I was just really excited for her to meet my first daughter. And so glad I did, just because she ended up passing away a few months after that visit. She was really a special person, very supportive of me. She bought me at least one book every week when I was younger. And I think she's one of the reasons I was able to do well in school, and likely one of the reasons that I developed an interest in geriatrics as well. So thank you guys for allowing me to reminisce with you. The next thing I'll talk about is the types of reminiscence. So this is really kind of how we reminisce. It's broken down into two categories. You can even break it down into a third. In research, you'll often see simple reminiscence talked about. So this is really what I just did. Unstructured storytelling, kind of going over past significant events. It can be used to teach others. And simple reminiscence is often used to enhance positive feelings. It's also often used to build connections between people. And then the other side of that is life review. This is a much more structured format of reminiscence. So it's not just kind of storytelling or remembering past events. It's really a reevaluation of those past events. And then to take that a step further, there's also life review therapy. And that's really more of a approach used in therapy to treat patients with depression. And there's many studies have shown that this is a great application and can be a really positive thing to add to a therapeutic plan for patients with depression. The functions of reminiscence I'll talk about next. That's really why we reminisce. So breaking down the different categories of why reminiscence takes place. There's social functions. So these are pretty common. These are more of the simple reminiscence. So often sharing memories, teach and inform, used to bond with others, enhance positive feelings. So really thinking of it as the simple form. There is instrumental functions. So these are things where you are wanting to build skills. It can be thinking back over past events that were traumatic or difficult, remembering what your coping mechanisms were during those challenges, and then you can utilize those skills moving forward for difficult times. Its instrumental functions can often be a way to process grief. And that's defined as intimacy maintenance, often in literature, but it's really remembering loved ones to help kind of process the feelings of sadness or grief for them. Another instrumental function I didn't list, but death preparation is also common, especially for older adults or anybody with critical or chronic illness. So and that's really looking back over your life, trying to develop a sense of calm with moving forward to the next step of death. And then integrative functions, these are more of a way to develop a sense of who you are, a sense of identity from reminiscing. And so this is looking back over your past life to determine who you are as a person. This can be a positive thing if you associate positive experiences over your past life with who you are today, but it can also be negative. And this is kind of, if you guys know psychology, Erik Erikson, this was the last of the stages of his psychosocial development. He talked a lot about kind of different domains that we go through throughout our life. And in older adults, it's ego integrity versus despair. And that's really kind of just what I stated before, looking back and how do you identify yourself? Is it through positivity, positive relationships, or is it through negative things? Do you associate your life with, negative failed relationships, failed careers, financial issues, and those things? So it can definitely go both ways. So how do we measure reminiscence? This is one of the most common scales used to measure the types of functions that are present in reminiscing. And these are the kind of 8 different categories that it breaks it down into, many that I've covered. Boredom reduction is often one we see when people are in unstimulated environments. I've talked about, I think most of them, intimacy maintenance, again, is the one where you process grief by remembering loved ones. Bitterness revival is one where you think back over your past and especially unjust experiences, and you really help to solidify or reinforce those negative feelings about what happened to you. So how do older adults reminisce? That was one of the questions I had. And so there's a few observational studies that I found from the Journal of Gerontology that used either sound bites of older adults and coded that into specific types of reminiscent function, and another one that surveyed individuals to determine kind of what are the most common functions of reminiscence that older adults use. And I think it really varied depending on different settings, history, and who the participants were reminiscing with. So for settings, private versus public reminiscence seem to have a split, with private being more of the instrumental functions. So that's the coping mechanisms, that is the death preparation and the intimacy maintenance to process grief. In public, not surprisingly, it's much more of the conversational reminiscence forms, but also teach and inform was a common reminiscence function seen in public. Personal history, one of the studies looked at participants in Israel compared to similar age older adults in Canada, and found really the Israeli participants that had personally experienced war within their own country had much higher rates of bitterness revival. And I think my suspicion is that probably translates to other individuals who have had significant trauma, that may be a reminiscence function that is more common for them. And then who we reminisce with also makes a difference. So older adults, when they're reminiscing with their partner, often it's more of intimacy maintenance, especially if they share, significant others they have lost. For children, it was much more teach and inform. And then for strangers, not surprisingly, it was more conversational. Another study compared functions of reminiscence across the lifespan. So this was the Canadian Journal on Aging, and it compared undergraduate students and the functions of reminiscence compared to older adults. And it was about 80 older adults over the age of 65. So this study was fairly small and probably difficult to generalize, but it gives us some information. And this really found that the younger adults had higher rates of boredom reduction, identity, and problem solving, with older adults having higher rates of teaching, informing, intimacy maintenance, and death preparation. Other studies that have looked at community dwelling older adults have found similar findings with older adults as well. And then one of the things that I found interesting with the study is it also compared the frequency, not just the type of reminiscence that took place, or the functions of reminiscence that took place. And there wasn't actually any increase in frequency or change in frequency compared to the older adults and younger adults. And so, you would assume with more life experiences, you would maybe have more frequency of reminiscence, but that's actually not the case. We all reminisce at all stages of our life. It may be that how we reminisce as far as the functions are different, but the frequency is likely similar. So all of those studies really looked at outpatient community dwelling adults. And one of the questions I had was, how do patients reminisce in a long-term care setting? And is that different? So this study, published in Memory Journal in 2017, looked at the functions and values of reminiscence for older adults in long-term residential care facilities. Again, this was a small study, in one location, so difficult to generalize, but it gives us some information and some differences. They looked at 46 participants in Connecticut. The average age was 86. The majority had cognitive impairment, either mild or moderate, on the MMSE. And then I'll kind of talk about the different metrics, but they used a variety of surveys and looked at kind of how frequent and who these patients were reminiscing with. They did surveys on depression, morale, and loneliness as well to look at correlations. And so those, with those metrics, that translates to the goals of this study. So they really wanted to determine whom and how frequently do older adults in long-term care facilities reminisce. What are the functions of reminiscence for this population? And are there associations with mental health and well-being? So this table just looks at how frequently the participants were either thinking about the past or talking about the past. And really the only note I wanted to make with this table, you can see the majority were thinking about the past, either, often and occasionally we're talking about the past, but these frequencies of reminiscence were were statistically significantly lower than when this data was compared to community dwelling adults. And so it's either, unclear the reason for that, and if it was just these specific population, if it had to relate to maybe their cognitive impairment was one thought, but that was just noted in the study. So the other thing they wanted to look at was who the long-term residents were reminiscing with and whether they had enjoyment and value from this reminiscence. And so this table has the who they were reminiscing, either alone, family, friends, other residents, or staff. And you can see the most frequent reminiscing partners were either themselves doing it alone or with family. And that really correlated with higher rates of enjoyment and value. And then at the bottom, the lowest frequency was with staff and fellow residents. And that also aligned with lower amounts of enjoyment and value from reminiscing with the staff and other residents. Others findings from this study that I found interesting was that when they reported on reminiscing with healthcare workers, 81% of the participants stated it occurred never or rarely. 68% stated that the staff never or rarely discussed their own personal lives with residents. And then only 25% of the participants expressed desire to increase sharing opportunities with their care providers, which I found surprising with the rates of reminiscence that they were experiencing being so low with healthcare providers. I assumed that they would want that increased, and that wasn't the case with this study. So this was the types of functions they found that these long-term care residents had. It's from at the top is the most frequent reminiscence down to the bottom. So as you can see, intimacy, maintenance, understanding the present, and teach and inform were the most common. The VFRS was just an additional scale. It was the value and functions reminiscence scale compared to the reminiscence function scale we looked at. And it just had a couple other categories on there of note. And then I highlighted a couple areas. So the yellow are the two functions that were significantly higher in the long-term care residents compared to their community dwelling counterparts. And then the ones highlighted in blue, those are actually much higher in community dwelling adults than long-term care residents. And so there was some difference there. The last thing the study looked at is it wanted to determine if there was any correlation between either the functions or frequency of reminiscence compared to morale, depression, and loneliness. They did this by looking at the morale scale they used was the Philadelphia Geriatrics Center morale scale. They used the geriatric depression scale, the GDS, and the UCLA loneliness scale. And then they compared that to the amount of and types of reminiscence that was taking place. And so as you can see, I highlighted the ones that were with the most statistical significance. If it has 1 star, it's 0.05 is the p-value. With 2 stars, it's 0.01. And then they also, for the marginal, it was a p-value of 0.09, but they also marked that there. But the ones that were most common was understanding the present, boredom reduction, and bitterness revival had the highest correlations to lower morale, depression, and then boredom reduction with loneliness, which I think, wasn't a surprise. If you are lonely, not having a lot of stimulation, that likely increases your chances of reminiscing to reduce boredom. The nostalgia score also was significantly higher. That's a 7-question survey asking how valuable, significant, and important nostalgia is for the participants. And so those that answered higher for that also had lower morale. And then at the bottom, I also highlighted there was an association as well with higher, those of the participants that desired higher increased reminiscence with the staff and residents also was associated with lower morale and depression. And I think that makes sense. If you are having decreased morale and depression, your desire maybe to connect with others would be higher. And they found that association here. All right. So the next thing we'll look at are what are the outcomes of reminiscence. We'll look at a few meta-analysis studies. There are tons of papers out there that look at reminiscence therapy compared to, for improvement of depression, cognitive impairment, quality of life, and other psychological well-being metrics. And so I just wanted to look at the pooled data. A lot of the studies, the majority of them, didn't show significant outcome, but a lot of the studies were very small and likely underpowered. And so I thought this was the best way to get an overall view of kind of what is the impact. So the first study was titled The Effectiveness of Reminiscence-Based Intervention on Improving Psychological Well-Being in Cognitively Intact Older Adults. This was published in the Journal of Nursing in 2020. The inclusion criteria for the survey papers were cognitively intact adults over the age of 60. And it compared reminiscence or life review, so that's the more structured types of reminiscence, or other narrative intervention to a control. Not all of the studies were randomized or blinded, of note. And then the outcomes they looked at were well-being, quality of life, life satisfaction, self-esteem, and depressive symptoms. So they found 31 total studies that met that criteria. The mean age of participants were 69. The majority of the formats used was simple reminiscence in a group format. There was a lot of variability within the interventions. The sessions amount ranged from 3 to 16. And then the duration of the interventions also varied from 1 to 16 weeks. And then each of the individual sessions also varied in length. So some were 30 minutes, some were up to 4 hours. So just note that a lot of these interventions were variable. So this first table looks at the overall effect of reminiscence on depressive symptoms. And as you can see, many of the studies did not have a statistically significant outcome. The metrics used, the majority had used GDS of note. Some used Center for Epidemiological Studies, and then one used the Hospital Anxiety and Depression Scale. They used standard mean difference just because there was so much, just because there was different metrics used to determine kind of differences between the study and ability to compare them. I highlighted the one that had the most statistically significant improvement, and that is the Schellman study. So this study was a study in 2009. It was for community dwelling adults, specifically it targeted African Americans. The average age of this population was 72. And for this, it was individual sessions. It was 8 weekly sessions. And then that was compared to either health education or a control. And they used, for this one, they used the Center of Epidemiological Studies depression scale, and they found a decrease from 14 comparison for the control or health education of 14, and then 6.8 was the score for the reminiscence therapy intervention. And then just of note, a depressive score is what I could find at least was the cutoff was 16. So even for the control group, they didn't meet the criteria for depression, but it did show some improvement in symptoms. And then above that, I don't know if you guys can see the Viger also had statistical significance. We'll talk a little bit about that study on the next slide. So this looked at the differences in reminiscence intervention versus control on life satisfaction. And really the only study that showed the statistically significant difference that really made up for the majority of kind of the benefit for the overall outcome was this Viger study. This one had group sessions, so this was different than the Schellman that had individual. And this really did 10 weekly sessions of group sessions for reminiscence. It was done in the Dominican Republic, and it showed overall improvement in self-reported quality of life for these individuals. Other outcomes that this study tried to look at but just didn't have enough data, or the studies were they felt too heterogeneous to compare, was self-esteem, psychological well-being, were not able to be completed. And then they also looked at quality of life, and that really wasn't able to be evaluated, or they didn't find differences, but the studies they found were pretty small, and so there was a concern that this was likely underpowered. The next meta-analysis I looked at was much larger. So this one looked at the effects of reminiscence interventions on psychosocial outcomes. This was 128 studies. The average age of the participants was 73. Again, similar to the previous one, the majority was simple reminiscence in a group format. And they looked at a variety of outcomes, depression, cognitive performance. They looked at well-being, ego integrity, which is that sense of kind of peace and a positive identity with reminiscence. They looked at life purpose, mastery, which is really having control, feeling the sense of having control over your life. And then they looked at social integration and death preparation as well. So this is the table of the outcomes. I've highlighted the post-test. So this is directly after the intervention. The follow-up, which we'll talk about below, was about 6 months after. K is the amount of studies included for that specific metric. G is the effect size they found. Z they have for statistical significance, and Q is the heterogeneity, which you can see is high in the majority of these studies. And really for the overall, they found positive benefits of reminiscence therapy that was statistically significant for all of these interventions directly after post-test. The ones that had the highest effect size were ego integrity, depression, and purpose in life. And then below is the follow-up. So this was roughly about 6 months, but it did vary in studies. I think the average was about a little less than 6 months of follow-up when they looked at all the studies. And I've highlighted the ones that maintained the statistical significance: depression, mental health, positive well-being, ego integrity, mastery, and social integration. So these were able to be sustained after when the follow-up period and they were reanalyzed. The ones with the highest effect size was ego integrity and depression. This study also had a lot of heterogeneity, so they looked at quite a few moderating variables to determine if there was any specific factor that really affected the improvement. And they found that overall there was stronger effects in life review therapy. They also found greater improvement in depressive symptoms for individuals that had depression or chronic physical illness at baseline. And that was compared to either those that did not have either of those symptoms or with patients with dementia. They showed less improvement in their depressive symptoms with these interventions. And then just of note, changes in positive well-being did not have any relation to pretest disease. And so this table just kind of highlights all of the different factors they looked at. And I've in the red box, I just highlighted the specific ones I talked about that they did find a difference. So that was life review therapy and life review had greater improvement. And then the depression and physical illness had greater improvement to either no health conditions at pretest or those with dementia. But they also looked at format, whether that made a difference, and did not find any difference in whether it was individual or group, the number of sessions, what the control condition was, the age of the participants, gender, the residence of the participants, whether it was published or unpublished. And then they also looked at study quality and didn't find a significant difference. So this reminiscence, now we'll move on to one that specifically targets patients with cognitive impairment. So this is reminiscence therapy for dementia. This was a Cochrane review of 22 randomized control trials. And I would say the overall kind of quality of these studies were a little bit higher with less heterogeneity. The trials had to include reminiscence therapy, and it had to have a duration of intervention at least 4 weeks or 6 sessions versus a control or no treatment. And then the outcomes they looked at included quality of life, cognition, communication, behavior, and mood. So this, the total participants in all these studies was just over 1,700. All had mild or moderate dementia. The average age of the studies varied between 78 to 84. And just of note, they were recruited from a range of settings, either long-term care facilities, hospitals, or outpatient clinics. So the first metric they looked at was improvement in self-reported quality of life. And I've highlighted really, individually, there was really none of the studies had significant improvement. But when the data was pooled specifically for the care home at the top, that one did show improvements for the data. And I can briefly talk about these, but the interventions varied. So the top one in the highlighted box is the Azukuru, sorry if I mispronounced that, study in 2012. And that looked at group a group life story group versus just kind of a casual discussion in a facility. And it did find a mild improvement on that one, an effect size of 0.2 to 0.4 for that intervention. The other one, the one below that, the OSHIA study in 2014, that one actually implemented reminiscence therapy as part of patients' care plan in nursing facilities for patients with cognitive impairment. And then the one below that, the subramanium one in 2013, that one had a small one in dementia care homes, and the ones in the control or in the intervention group had reminiscence individual sessions versus just a control without any intervention. And as individually, as I said, none of these studies had significant effects, but together it looks like maybe there is some improvement in self-reported quality of life for care homes. This one I'll just go over briefly. This looked at changes in cognitive performance, and really overall there wasn't a significant change that was clinically significant. There was a marginal change when they pulled all the data, but likely when they looked at it, wasn't a really something that would be notable clinically. And then similar, this one noticed that improvement right after the reminiscence therapy was noted, but when they looked at kind of overall intervention for post-test, that it wasn't sustained for the majority of studies. And then this one looks at improvement in communication and socialization. This was primarily reported not by the patients, but by by either their caregivers or healthcare providers. And there was two, overall, the pool data did show that there was a significant improvement with the intervention for socialization and communication for these patients with cognitive impairment. The height one included a life review book where they would do reminiscence therapy and help the patient make a life review book. And then the Tadaka studies looked at group reminiscence therapy. They had participants with the AD is Alzheimer's dementia, the VD is those with vascular dementia. And that one they consisted of for the intervention group, and it was a cluster randomized control trial. They would have basically reorientation at adult day programs, and they found that the patients had improvement in disorientation and withdrawal. And so, both of these were, I think, notable that either in the care home or community, having reminiscence therapy could maybe improve behaviors and should be another technique to be considered. Another study that didn't specifically have reminiscence therapy, but I thought was interesting, looked at using reminiscence therapy as part of a multimodal plan for patients with dementia. And they really found that overall they had statistically significant lower amounts of antipsychotics prescription. And so I think, reminiscence therapy is definitely a great additional tool that we could think of as far as adding to patients with dementia to improve behaviors. And this study, or this last metric, was just looking at depression, and kind of similar to what we saw in the previous meta-analysis. There wasn't a statistical improvement for any of the studies or the pooled data when they looked at reminiscence therapy as an intervention. All right, so those were all the meta-analysis studies to kind of look at what's the general outcomes of narrative medicine. But next we'll look at some implementation in different settings as well. This one is a narrative medicine in an acute care setting. So this was done here at our institution in Colorado. It's called Connection, the integration of a person-centered narrative intervention into the electronic health record and implementation study. And so this was a program that really wanted to see if we could implement narrative medicine, what would be the barriers to that? And is it usable? Is it beneficial, one, to the patient, but is it also beneficial specifically to the bedside nurse? And so they interviewed hospitals patients. The prompts included how illness impacted their lives. And then, like I stated, they wanted to determine barriers, usability from perspective of the bedside nurse and the patient. These are the study characteristics of the patients. So there was 20 patients included with an average age of 52, so definitely younger than our typical patient. The majority were male, and then the majority either were Black, Hispanic, or Latino for race, ethnicity. Length of illness varied, and then the type of illness they have at the bottom. The majority had heart failure, but also some with ESRD and then cancer. These are the nurse characteristics. So there was 18 bedside nurses included in the study with an average age of 31. Majority were female, white, and then an average age in nursing was 5.7. So these were the nursing outcomes after the completion of the study. The barriers that the nurses reported were time to read the narrative, researcher interrupting nursing care. So when nurse reported, it was difficult to get vitals when the researcher was in there doing the interview. Some reported feelings of sadness when reading the narrative, and then difficulties being notified or finding the narrative in the electronic health record. The benefits they reported really all described this as a positive experience. They reported better understanding and different perspective of patients, better connection, increased empathy, improved patient compliance, and then observed benefit in patient mood and patient interactions with staff. The patient outcomes, so the barriers reported included produced sadness when going through this project. One reported that the story was not told in their voice. Having to help in editing while hospitalized was difficult for some, and then concern that the narrative would negatively impact their treatment was reported by one. The benefits really, majority found easy and enjoyable experience, emotional, but in a beneficial way, and then most would want to participate in a similar experience in the future. I won't read all these, but these were some quotes that I found in the study that I thought were really meaningful. I'll read the second one from the left, but this was what a nurse stated. She said, "It was a help, it was a coping thing. It helped me cope with being there at the time because, or I'm sorry, this was one of the patients. It was a help, it was a coping thing. It helped me cope with being there at the time because I've been really having to come to face with my mortality and everything else like that. And it helped me cope." And so with that, I thought of, this is kind of instrumental reminiscence. This is the patient using their narrative to really help them cope with the current struggles and situations they're going through. And then the last one on the right by the nurse, I thought this was really meaningful, but the nurse stated that he was actually one of the patients I was actually struggling to get to know. We didn't have that connection like I did with other people. Then we talked about his story, and it was no longer like a checklist. It became more personal. That's why I really liked it, because you were a patient that I didn't necessarily feel a connection with, but I understood this is more of who you are. You're not just a patient in room 300. And that really showed that narrative medicine can kind of bring that humanism back to providers as well, and not just be beneficial for patients. So briefly, I'll kind of go over just some other, ways, how else can we implement narrative medicine? I'll talk briefly about the Medical Student Narrative Book Project. Coasted, I won't go into a lot of detail, but I think as older adults, if one of the functions that's important to them in regards to reminiscence is to teach and inform. I think Coasted is a great way for older adults to be able to take part in simple reminiscence with other medical health trainees. We'll look at a couple of veteran group sessions quickly, one in home-based primary care and one in a geriatric mental health clinic. But I think that group, really has a lot of trauma, mental health, and I think they uniquely can benefit from group sessions, especially the fact that they share in similar traumas and life experience. And then we'll talk briefly about My Life, My Story, which is a VA program that includes narrative medicine in an outpatient setting. All right, so this study looked at implementing group therapy, reminiscence group therapy into home-based primary care. Obviously, it was veterans enrolled in home-based primary care. It was a large geographical area in the Midwest. The main thing is they just wanted to evaluate feedback to the reminiscence. So they didn't look at other metrics for this, but just wanted to determine usability and if it had a positive feedback. It included 6 60-minute telephone sessions with pre-work provided by a workbook. And overall, unanimously, post-participation feedback found meaning in shared experiences and feelings of connected to others and self. And so I think, these are individuals that are most vulnerable and isolated. And so being able to give them the opportunity to take part in a group reminiscence therapy, I thought was a really interesting and unique and useful intervention. This one was conducted in Geriatric mental health clinic, and this was bringing creative writing instruction into reminiscence group treatment. And so it was group reminiscence, but also had a creative writing aspect as well. There was 34 veteran participants. Really the only exclusion criteria was that they could not have, significant psychiatric decompensation where they weren't able to participate, whether that was mania, psychosis, or significant cognitive impairment. This was multiple 1-hour sessions over a period of 10 weeks, and they looked at pre and post-test depression using a PHQ-9. The outcomes for this intervention, so the pre-test PHQ-9 score was 12.17, which is moderate depression. And then the post-test PHQ-9 mean score was 8.2, which is mild. And this was statistically significant. And I think we can all say clinically significant too. And, really, there's a great tool to think of as far as adding something when we have patients with depression that may be really beneficial, including to kind of all our other interventions. So My Life, My Story, this, I don't know if anybody's heard of it. They talked about it on the Jerry Powell podcast recently, but this is a VA-led initiative. It was developed, I think, in 2016, and it's where they'll have medical trainees, whether it's medical students or other trainees, that will interview patients. They will then type up their story, allow the patient to read it, edit it. The goal is for it to be written in the patient's voice, and then with the patient's permission, it will be implemented into their medical record. This has included, as of right now, 800 learners nationwide. It's expanded to over 70 VA medical centers with over 5,000 stories. There's like some videos that have some testimonial from this, and it was really special. One talked about a veteran with who had never talked about his history in Vietnam and decided that he wanted to share that. And he got a printout of the story, and he had never talked about with his family. And so he was so excited to be able to finally, share this part of his life. And he was able to pass out that letter. Not only was it put in his medical record, but all of his family members were able to receive a copy too. And the student that interviewed him said that this was the most impactful part of his medical training so far. And so I think it really speaks to, how narrative medicine can improve not only patients, but also providers, and really have better patient-provider relationships. And then last, the Medical Student Narrative Project book. So this was a project that Dr. Blumen and I started when we were fourth-year medical students, where we interviewed volunteers from seniors clinic and typed up their story with their help in the edition, and then got it printed in a book. We had a celebration that year, and unfortunately haven't been able to celebrate since due to COVID, but planning to have a celebration as the fourth book will come out this year. And I think, this was, I hope impactful for the participants, but for me, this was really meaningful. So many amazing stories. One I can think of was this amazing woman who had survived an escaped communist regime in Czechoslovakia back in, the late 1940s, was able to come to the United States. And then she rose up and became just this amazing pioneer and engineer in aerospace in her field. And, that was just one of the many great stories. And so I think it's just a great resource we have is stories. And so to get those permanently put in books for all of us to read is just a really neat project and experience. So that is all I have for today. The conclusions, just to briefly go over, reminiscence is something that we all do. It's present across a lifespan, and it can vary based on age, setting, and personal experiences. Reminiscence can be used therapeutically to improve mental health, life satisfaction, and it can be implemented in a variety of settings. For persons with dementia, I think it can improve communication and quality of life, especially for those in facilities. And then I think overall for healthcare workers, likely benefits, and this is just thinking of my own experience, the My Life, My Story, but also the connection story too in the acute setting, that it likely benefits for healthcare providers and can improve patient-provider interactions. All right, thank you all. I will open it up to questions.
All right, thank you so much, Hannah. There's one question. So again, either on the Q&A or the chat, you could submit your questions. From Dr. Levy, there's a question regarding My Life, My Story. And the question is, are outcomes data being collected on this project?
I couldn't find, I didn't dig deep, so I have to look more because that was a question I had. This was kind of something I added towards the end. So I don't know, but when I looked through their websites, I couldn't find anything obvious, but something I have to dig more into.
All right. I have a question. In your research for this talk, did you come across anything in the outpatient setting? So for example, some of the things that connect us to our patients, we think, are, the small talk, asking them about their family. Or were there any studies formally looking at a small dab of reminiscence therapy in the outpatient setting?
There might have been, like, with some of the, because some of them had shorter interventions, and for all of the meta-analysis, I didn't go through all of the studies, especially if there wasn't statistical significance or didn't have a lot of positive outcomes. So there could have been, because there was sessions that were like short, like one session for 30 minutes. So I'd have to go back and look, especially the first meta-analysis had some with really short, brief interventions, which I think is what we would end up implementing in ours, but I'd have to go back and look at those.
Great. Another question from Dr. Wallace. Do you know if medical student curriculum includes any narrative and medicine content?
So we volunteer students for the project. I don't think there is, at least in our institution, aside from like volunteering for our for like the medical student book. I know the VA, and my question was the My Life, My Story, if that was something, whether it was volunteer or just something that was kind of like a requirement. I would say though, like, I would hate to require a student to do it if they weren't like something they were passionate about it, just because it could end up being something, negative for the patient, or you would want both participants to be willing to do it. That was I was curious if the My Life, My Story, if that was like a requirement for students, because it didn't state, it just said student learners. But I would assume they would be volunteers. Yeah.
I wonder if, in our curriculums, we teach students how to communicate with patients, not just the basic questions, how to gather the information, open-ended questions, et cetera. But if there's any role for in the humanity of medicine and teaching them to ask perhaps some of these questions during their history taking.
Yeah. I think, because we are trained to like do HPI in a very structured way, but like narrative medicine is like just open-ended prompts often about, tell us about your life or what's personally significant to you that you would want to share. And I don't think, that's not something where we were ever really trained to ask. But I think can be really valuable to get to know patients and have them feel more comfortable with us.
A question from Dr. Nearing. Again, she thanks you for the presentation and your leadership in the SAGES project. She wonders if RMR, I think that's Rocky Mountain Regional, participates in My Life, My Story, and if so, who leads that effort locally?
I don't think we do. So I was hoping, especially if to maybe bring that to the VA in years to come. But I don't think we are part of the 70 VAs that include it yet.
According to Dr. Levy, yes, we do.
Oh, yes, we do.
From Dr. Johnson, I noticed that the UC Health inpatient study listed sadness as a negative outcome. Did you find anything in other studies that would also consider sadness as a negative, or can this be an expected part of reminiscence?
Yeah, I think I had on, that was like a thought of like, is reminiscence like producing trauma as well in negative outcomes? I think the one thing that I've seen from the studies that's encouraging is that depressive symptoms, although there's not like a statistical significant improvement, it doesn't worsen. And so that was that was one metric that I found when I heard that, you know, sadness. And that's a thought, like, especially when you're talking about trauma or things like that, it's a concern that maybe you're having trauma and how do you deal with that from those negative feelings. But I think the fact that depression doesn't worsen with the intervention is something that at least was reassuring to me, that it's not a harm. And that maybe, you know, that feelings of sadness is kind of a normal, can be a normal and positive way to process those emotions, but won't necessarily have negative outcomes as far as mental health.
Great. I have a question. You know, going forward, I know you're going to be over at the VA. What next small or large steps might you take in exploring reminiscence therapy in the outpatient setting in particular, but with learners that you have over at the VA?
Yeah, my hope is to like include the My Life, My Story as part of kind of a normal function for our geriatric clinic, would be one goal. And I think, you know, especially we get, you know, when patients are referred to us, similar to seniors clinic, it's toward, you know, they're often in their 80s, they have quite a bit of history. We're able to find their medical history, but to have like such a rich piece of literature about them in their chart that we could read through, I think would really, you know, to help us to transform their care. And I think asking them, you know, what matters most, even, you know, we get like a little bit of an answer, but I think being able to read their life story would really help us to understand, you know, what matters most to this veteran.
Great. There's a comment in the chat that Anit Tyagi is leading the My Life, My Story project at the VA, the effort. He works in a lab in the VA and leads this effort in his free time. Needs to be studied, Hannah, exclamation point.
Okay,
so there's
good.
your future.
Okay, that sounds great. Thank you.
All right. Other questions, comments? All right, great. A very interesting topic, I think probably close to a lot of our hearts with our elderly patients. And in studies like these, with small studies, and also with qualitative data, often difficult to study. So appreciate your efforts in bringing this talk to us. And I will close us out and thank you again. Again, in 2 weeks, Dr. Blumen will be presenting, and we will make a note of whether or not that will be a hybrid session or fully remote about the week before the talk. Thanks again.